Welcome back, ladies and gentlemen. We now commence the afternoon session, starting off with our first guest lecture on dissecting the role of the eosinophil in asthma, presented by Professor David J. Jackson.
Hello, my name is David Jackson. I'm a professor of respiratory medicine at King's College London and head of the Severe Asthma Centre at Guy's and St Thomas's Hospital in London. Thank you very much for inviting me to speak today. The topic of my talk is specifically the role of the eosinophil in asthma. And this has been increasingly a very interesting area within asthma because we have appreciated that with the advent of the new biologic therapies that target specific pathways, it allows us to really start to delineate the immunology of asthma and the key cells that drive disease. It's important to remember first that probably less than 4% of patients with asthma need escalation beyond high-dose inhaled therapy. And this is a really important study from the Netherlands, where they looked across the population. They took a sample size of just over 2,000 people, and they saw that across the population in the Netherlands of people with asthma, 24% were on moderate to high dose treatment, GENIUS step 4-5, of which 17% were poorly controlled. But once adherence to inhaled steroids and inhaler technique was corrected, actually the 17% fell down to 3.7, which is equivalent to an 80% improvement in the numbers of people who remain poorly controlled, really highlighting the key role of confirming adherence to inhaled steroids, making sure inhaler technique is optimal. The question then is, well, is targeting eosinophilic inflammation sufficient for the rest, the other 4%? Because clearly it is enough, because inhaled steroids work. One of the key ways they work is by targeting eosinophilic inflammation. It's clearly sufficient for already 96%. And just to show you an example of the impact of improving adherence, increasingly we're using now electronic monitors that connect to the inhaler of the patient, the preventer inhaler, and then their smartphone. And this is one such device. It's made by a company called Propeller. And this is two screenshots of patients, one on the left, one on the right, of our patients. Essentially, I know it's a little bit difficult to see, but this is over a period of a year on the x-axis, and then you've got the proportion of how adherent the patient is to their daily use of inhaled steroids. The more blue there is, the more adherent they are. And so you can see the patient on the left is very adherent, the patient on the right is less adherent. And this is a patient of mine. This was actually the first patient I ever put an e-monitor on in our clinic. You can see this was back in April 2021. And this is a screenshot of the full blood count at the time. She had an eosinophil count of 1,000, 1.0, depending on which units you use. Now, we connected her to this e-monitor, and these are the blood results for the rest of the year. Now, we repeated it 2 weeks later, and you can already see the eosinophil count has dropped from 1,000 to 400. Not with a fancy, very expensive biologic or any escalation in treatment, simply by discussing the role of adherence, connecting her to an e-monitor to support her adherence with this achieved. And actually, she went from someone with 5 exacerbations in the previous year to 1 in the next 12 months. Now, inhaled steroids do not only target the eosinophil. And this is a study 12, 13 years ago now, just showing what happens before and after 1 month of inhaled steroids in patients who are inhaled steroid naive. And you can see, as expected, the FeNO falls. FeNO is a marker of IL-13 and one of the key T2 cytokines. So inhaled steroids suppress this as well. And here you can see it very clearly that it's IL-13, because on the left, what I'm showing you here is a drug called lebrikizumab, which specifically targets IL-13. This is different from dupilumab, that targets the IL-4 receptor, which targets IL-13 and IL-4. But this is specific to IL-13. And what you can see very easily is that the FeNO level sort of drops off a cliff within a week of starting an anti-IL-13, telling us that it does fundamentally reflect IL-13. And on the right, you can see the impact of inhaled steroids on FeNO level in a group of patients, either given 100 micrograms of fluticasone propionate or 500, showing this is again in ICS naive patients, how quickly FeNO falls. So does that mean then inhaled steroids could work, not necessarily by targeting the eosinophil, but by targeting IL-13? I think it's important to look at the biologics here, because the biologics are the ones that really tell us what specifically the steroids are fundamentally doing, i.e., if you only target IL-5 or the eosinophil, that then tells us the critical role of the eosinophil of the IL-5 pathway. In terms of the main biologics we use, and I'm not including omalizumab here because it is slightly different, but all the newer biologics essentially in one way or another inhibit airway eosinophilia. You have mepolizumab and reslizumab, which are serum neutralizing antibodies for IL-5, benralizumab, that in contrast targets the IL-5 receptor and through a mechanism called antibody-dependent cell cytotoxicity essentially depletes eosinophils very, very quickly. Dupilumab targets the IL-4 receptors I've mentioned, which essentially stops trafficking of eosinophils from blood into tissue, which is why you get in some patients a hypereosinophilia in blood, because it sort of puts a dam on the movement from blood to tissue. And then tezepelumab is the latest biologic. It's only approved in a few countries so far. And this, by inhibiting TSLP upstream, TSLP being one of the epithelial-derived cytokines, it inhibits IL-5 and 4 and 13 production by the key cells that drive T2 immunity, those being the Th2 cell and the ILC2. What is very clear when you look at the relationship between the blood eosinophil count and asthma is how closely it links to risk. Risk of a severe exacerbation, which you can see on the left here, looking in a very large number of patients, this is from the UK, and the relationship and the risk, this is essentially the odds ratio of developing a severe exacerbation in relation to what their blood eosinophil count was. And on the right, the ability to maintain good asthma control. Again, showing very clearly the higher the eosinophil count, the more difficult it is to maintain good asthma control. So a very clear link there. So what might be driving this specific issue? Well, symptoms can be from a lot of things, and so symptoms obviously underpin what is recorded in control. But one of them is airway hyperresponsiveness, how twitchy the airways are. And we know now quite clearly that the eosinophils are important in airway hyperresponsiveness. For some time, people thought inflammation and airway hyperresponsiveness was separate, but this is incorrect. They are intrinsically linked in asthma. On the left here is important work. These are both papers published in the last 6 months or so. On the left, really showing that the presence of airway hyperresponsiveness in asthma was linked to where the eosinophils were. The presence of intraepithelial eosinophils, which are staining brown here, that you can see in panel C. These are patients. Panel D is obviously a higher magnification of panel C. Panel C is patients with asthma with airway hyperresponsiveness versus panel B, which is on the left, patients without airway hyperresponsiveness with asthma, and then of course the healthy controls in A. On the right, importantly, there's a really nice study by Rory Chan, who has been working with Brian Lipworth in Dundee in Scotland, and a very elegant, simple study of what happens to airway hyperresponsiveness after you deplete eosinophils in a very direct way with benralizumab. You can clearly see here that by week 8, which is essentially at the time of the third benralizumab dose, there's already statistically significant reduction in airway hyperresponsiveness that reaches a peak at week 12. It's important to remember, though, thinking about control, that if you have a patient who, for example, is on a biologic that targets eosinophils or is on steroids that also deplete eosinophils and T2 inflammation, if they are still symptomatic, why are they still symptomatic? Because sometimes there are other conditions that drive those symptoms. And so here, I just want to remind you of the issue about comorbidities. And interpreting the lack of a response from a symptom perspective. One of the two questions within an ACQ, the asthma control questionnaire, is of course activity limitation, shortness of breath. But if you think about a patient who, for example, has a BMI of 45, who's very obese, then they will also score very highly on this, whether or not they have asthma. And this was an analysis that we looked into to try and understand this in a bit greater depth. This is data that was presented at the British Thoracic Society about 2 months ago. This is data from the UK. It's multi-center, looking at the effect of benralizumab, so eosinophil depletion, after 2 years of treatment. And here we're looking at two groups: patients with a normal BMI on the left, BMI less than 30, and patients with a BMI of between 30 and 40, approximately 100 to 120 patients in each arm. Now, the first row is the exacerbation rate. And what you can see is the baseline exacerbation rate in those with a normal BMI was 4.6. Those with a BMI of between 30 and 40 was a bit higher, actually, at 5.7. So these are very severe patients with a very high exacerbation rate. But actually, after 2 years, even after 1 year, the exacerbation rate is fundamentally the same. It sits at about 1, i.e., eosinophil depletion has basically got rid of nearly all the exacerbations with 1 left. And this is almost certainly going to be a bacterial infection, probably. But what I really want to concentrate on is the ACQ. You can see here that the ACQ at baseline is 2.7 in those with a BMI less than 30 and 3.3 in those with a BMI more than 30. Just for the benefit of those of you who don't use the ACQ, less than 1.5 is considered controlled, number one, in asthma, and the MCID is 0.5. The lower the number, the better. So 2.7, 3 is considered, obviously very symptomatic. Now, after 2 years, in the patients with a BMI less than 30, you can see that their ACQ was 1.3. In those with a BMI more than 30, it was 1.9. The actual delta, the change, the magnitude of the change was the same. 2.7 to 1.3 is 1.4. 3.3 to 1.9 is also 1.4. The improvement was the same. It's just that the persisting symptoms in the more obese patients meant that the level was higher. And this we see at the bottom line when you look at the number of patients that were able to get to an ACQ of less than 1.5, because actually, if you had a BMI of less than 30, 66% essentially could become completely controlled, whereas those with a BMI more, only 42%, even though they had a similar exacerbation rate. So it's important just to remember when interpreting symptom scores in patients that have extrapulmonary comorbidities that could drive respiratory symptoms. What about exacerbations? What is it that links eosinophilic inflammation with exacerbation risk? Well, it's important to remember that the most important driver of exacerbations in asthma are respiratory viruses. And this has been known for a long time. We can see this relationship very clearly when we look over a longitudinal study such as this, over 10 years, where the peak of exacerbations occurs the same time every year in relation to the autumn months in the Northern Hemisphere here. This is in a cooler climate where you can see a spike in respiratory virus-related exacerbations, and this is most commonly rhinovirus. Now, what are the mechanisms behind this? Fundamentally, there are two. The first is there is an inappropriate T2 response to the virus in patients with asthma. The normal response, if you're healthy and you don't have any sort of allergic asthma disease, is a T1 response. That's a normal evolutionary response to infection. You have a Th1 response. But in asthma, there is an inappropriate T2 response. What is the evidence for this? Well, when I did a study, which was published in the Blue Journal in 2014, where we infected patients with asthma, we inoculated them with rhinovirus, we could clearly see that in those with asthma, the levels of T2 cytokines went up. This is just simply showing IL-5 here on the right and the top. And we also did 2 bronchoscopies, one before infection, one in the midst of the infection on day 4 post-inoculation, showing clearly there an increased proportion of eosinophils in the bronchoalveolar lavage in patients with asthma compared to those who did not have asthma. The second mechanism, though, is that there is an impaired antiviral immune response. And this we can see from in an in vivo setting simply by looking at virus load. Here you can see in red the asthmatics, black the healthy. This is a logarithmic scale again, looking at the days post-inoculation, where the higher the asthmatics had a higher virus load, i.e. a greater virus replication, a poorer antiviral response. Now, this has been shown in vitro in different settings, and what we now know is that there is a clear relationship between these two factors. And this is one of the most important studies that actually been published in the last year that really builds on this explanation. This is a very interesting study done in the US where they took dendritic cells, plasmacytoid dendritic cells. Now, these dendritic cells are one of the key sources of type 1 interferon. Type 1 interferon, interferon alpha, is one of the key antiviral interferons. And what they did was they took these cells, they cultured them in the presence or absence of eosinophils, and then infected them with rhinovirus. And what you can see in panel A in the top left here is the interferon responses of these cells in the presence of eosinophils when infected was diminished compared to the dendritic cells that were not cultured in the presence of eosinophils. On the right in panel B, you can see that this was present in a dose-response way, where the more eosinophils there were in the culture, the more suppressed the interferon response was. And in the bottom panel A, which was from a different figure in the same paper, they showed that even the supernatant of eosinophils, even if you didn't have the eosinophils themselves, if you took the supernatant of activated eosinophils and then put that in the mixture with the cultured dendritic cells, the same thing was seen. And finally, what's important is, and this sort of dose response then relates to what we saw earlier with the dose response between the level of the eosinophils and the risk of an exacerbation that is severe. What they also then showed from a different figure in the same paper again is that then dendritic cells taken from patients on mepolizumab or benralizumab had a normalized interferon response to infection compared to those with ongoing eosinophilic inflammation not on these therapies. And this is why when we look at this study here in kids who were given mepolizumab for their asthma, we see that there was a reduction in exacerbations specifically at the time of the virus peak. We can see here in red, placebo, in blue with mepolizumab, that if you target eosinophilic inflammation, those kids, they still get the same number of viruses, but those viruses don't turn into an exacerbation. This is what we see then when we look at 5-year data for benralizumab. This is long-term data, 5 years with eosinophil depletion. But suddenly you go from a baseline exacerbation rate of about 3 per year down to, on the average of less than 1, 0.2, 0.3, 0.5 exacerbations per year. What this actually equated to in the study was that more than 75% of patients on benralizumab each year had 0 exacerbations. They had no exacerbations whatsoever, even though we know that everybody still gets respiratory viruses, on average 2 probably per year, some more, some might be lucky and only have 1, but pretty much everyone gets minimum 1, usually 2. What then is the role of allergy? How important is allergy? What I've spoken about is how important the eosinophil is. Does it matter then whether it's allergic inflammation driving eosinophils into the airway or non-allergic inflammation driving eosinophils into the airway, such as respiratory viruses and pollution, or just intrinsic inflammation, which is independent of any extrinsic trigger? Well, we looked at this, and this is a study where we looked at the response to a combined group of mepolizumab and benralizumab patients. This is just from our center, 230 patients. We published this a couple of years ago in the ERJ, and we simply looked at the response in those who are eligible for omalizumab, so eligible for anti-IgE. They've got perennial sensitizations, they've clearly got allergic inflammation, compared to those patients who are not eligible for IgE. Now, what we saw is that actually it made no difference in terms of the exacerbation rates in panel A, or the ability to wean the patients off maintenance prednisolone in panel B, or the change in asthma control, or the change in lung function in panel C and D, in relation to whether or not the patients were allergic and sensitized and so on. And this similarly is what we see when we look at this data here. Now, this data is a post-hoc analysis of the phase 3 study of benralizumab, simply looking at the relationship between the baseline IgE, this is the total IgE, and the exacerbation rate during the study. And there are two important messages in this data. The first is looking at the placebo arm, because what the placebo arm in gray tells us is that IgE, unlike the eosinophil, is not a biomarker of risk of exacerbations. You can see that the patients who had an IgE of 200 or 1,000 or even 2,000 had exactly the same exacerbation risk. The second thing you see is when you look at the benralizumab treated patients in pink, the exacerbations were reduced irrespective of what that total IgE was. Again, the reduction was similar whether it was 200 or 1,000 here. This is much larger data now in patients who have no eosinophils, who are on anti-IL-5 receptor therapy, benralizumab. And this is data from about 6 or 7 countries. It was a study called the JALOC analysis, which was presented at the ERS last year, and 800 patients approximately. And again, you see that patients who were atopic, there were 365 of them where it was known here, still had an 84% reduction in exacerbations. And numerically, there was slightly greater reduction in those who were not atopic, but it wasn't statistically significant, and fundamentally you're still getting, over 80% reduction. What about FeNO? Because FeNO, as I mentioned earlier, is a marker of IL-13. So you could say, well, if you have a high level of FeNO, then arguably that's the key thing you should be targeting, not the eosinophil. But actually, the same cells that produce IL-13 are the cells that produce IL-5 and therefore drive eosinophils into the airway. What we see in reality is that most patients who have a high FeNO, this is simply a marker of the fact that there are eosinophils in the airway. And this you can see when you look at the patients here who've got a FeNO of more than 50. They were actually the ones numerically who had the greatest reduction in exacerbations. This is a really interesting, what we also saw in terms of FeNO was that actually it can fall in some patients with benralizumab. And this is a screenshot of one of the first patients we actually gave benralizumab to in our center. You can see here, this was May 2018 when we started benralizumab. Now it's a busy slide from the screenshot of the computer. I just want to highlight what happened to FeNO, because each column here is a dose. And you can see you starting in May, ending in the next year in April, the end of April 2019. And you can see that the FeNO actually fell. And when we started noticing this, it was really surprising because it was not something that we were expecting. The only explanation for a FeNO falling beyond the drug you're actually giving them now is you could say, well, they've started using their inhaled steroids more. What we actually know is that the reverse happens. In fact, patients who feel better on biologics use less and less of their inhaled therapy because they feel better and don't feel they need it. So you would expect, if that was the reason, the FeNO to go up, not to go down. So why is it the FeNO goes down? And actually we see this, we've done a separate analysis that we published looking at this. And what we saw is that patients with the highest FeNO levels, this is FeNO of more than 75, comparing baseline to at 1 year, did have a statistically significant fall in FeNO. This you can see on the left is 229 patients. It's a mixed cohort of mepolizumab and benralizumab. There was 57 patients in this highest group. And telling us again, and the reason, I think we see this, is what we often forget is that the eosinophil itself is an important source of IL-13. So when you remove the eosinophil, you're not simply removing the eosinophil only, you're also removing whatever it produces, which is IL-13, other key cytokines, growth factors, enzymes that drive and connect with the other cells of T2 inflammation and drive T2 pathways. What then is a non-responder to eosinophil depletion? So far, I've hopefully made the case to you that the eosinophil is critically important in asthma. Targeting the eosinophil is highly effective. Does that mean it is for everybody? Well, when we looked at our paper, and this was the first large cohort published in the real world for benralizumab, we published this about 2 years ago in CHEST, we saw overall there were 15% of patients who actually didn't have a good response. When we looked at 1 year, to benralizumab, to eosinophil depletion. And these 15% really fell into three groups. The first were those who, in truth, probably did have a good response. Well, they did have a good response initially, but then developed antibodies to the drug itself, anti-drug antibodies. And here these were identified because the eosinophil count, which had been sort of 000, suddenly jumped up. The second group were those that had chronic bacterial airway infection. And these 5% approximately of the total were identifiable by actually having really low, well, they still had a low eosinophil count because they were on benralizumab and it was working, but they also pretty much had a low FeNO in most cases. And then they had the symptoms of chronic airway infection, sputum, a suboptimal response to prednisolone or inhaled therapies in the same way. And obviously you can culture the sputum and you identify the problem. Most of these patients also had this sort of grumbling CRP of somewhere between 8 and 20. Every time you did bloods on them, they still had the CRP. It really identifies patients with chronic bacterial airway infection. The third group are very interesting because these are patients that actually still had very high levels of T2 inflammation, which were identifiable by a very high FeNO. They didn't have any eosinophils because of benralizumab, but they still had symptoms that were steroid responsive. Symptoms that are steroid responsive in asthma tell you immediately those symptoms related to T2 inflammation. The high FeNO confirms this. And these patients, when we gave them dupilumab, did very, very well. Dupilumab targeting IL-13. And this is a subgroup, that is that specific subgroup of patients that did not respond well to benralizumab, that did not respond well to eosinophil depletion, but had very high FeNOs that then responded very well to targeting the IL-13 pathway. You can see here, this is 32 patients. On the left, this was presented at the American Thoracic Society last year. On the left is the exacerbation rate, which was 6 prior to starting the IL-5 therapies. It did actually improve on IL-5 therapies, but they were still nonetheless exacerbating at least 3 times on average. And you can see when we switched them, exacerbations basically disappeared. Same with symptom control, that significantly improved, and lung function that significantly improved as well. Really impressive improvements in lung function, switching to dupilumab in this cohort. And the one thing that identified the super responders compared to the others in this group was FeNO. And actually, they had a very, very high FeNO. The average FeNO was 116 parts per billion here. The others still had an elevated FeNO. It's not that they had a normal FeNO, because you can see here it's 50 and 53. It was simply that they had a very, very high FeNO. This is important because it can drive airway remodeling and bronchial wall thickening. And that's what we really see on CT scans. And this is a patient of mine that had a persistently elevated FeNO of more than 100, despite confirmed adherence to inhaled corticosteroids. These are 2 CT scans from the same patient, one in 2016, one in 2020. And I've tried to take exactly the same slice for a fair comparison. Hopefully you can see that there is clear thickening of the bronchial walls here in the context of uncontrolled T2 inflammation. And this links to another area and the role of the eosinophil and T2 inflammation in asthma, which is of lung function decline and airway remodeling. On the left is data showing over a period of time the relationship between the change in FEV1 and the blood eosinophil count in patients with asthma. You can see that the higher the eosinophil counts, the greater amount of lung function those patients would lose over time. On the right is a very interesting study from New Zealand over 17 years, showing actually that this relationship was present even in patients without a diagnosis of asthma who didn't smoke, suggesting that eosinophils in the airway, even in the normal population, over time lead to some airway remodeling, some loss of lung function over time, and are more likely then to lead to the diagnosis of an obstructive lung disease. Another key point about the role of the eosinophil and whether there is a difference across asthma is evident when we look at the post-hoc analyses of the studies that target the eosinophil, in this case, benralizumab. Here what we see is that actually the patients with adult onset asthma were the ones that really did very, very well and was driving the main response. And in fact, patients who had child onset asthma didn't have such a good response. Now, this is, of course, changed compared to placebo, and there's always a large placebo response. So it doesn't mean it doesn't work at all in child onset, but it was harder to show a difference with placebo. And this is reslizumab data, which is one of the other lesser used anti-IL-5 therapies. It's lesser used simply because it's intravenous, so it's more practically difficult. Again, showing the same thing, that when you looked at the response in the context of the age of onset of the patients, it was clear that the older the patients, or at least the older the age of onset of the patients, the greater the response. And we see that again, if I come back to this mepolizumab study in kids, that actually the overall reduction in exacerbations compared to placebo was pretty small when we think about biologics generally. You can see here the rate ratio is 0.73, 27% reduction in exacerbations. Most biologic studies in adults are 50% approximately. And when we looked at them in our cohort of benralizumab, we could see that the patients with adult onset disease were the ones who are most likely to be a super responder, clinical remission, essentially patients, they feel like they don't even have asthma anymore, no exacerbations anymore, completely able to come off their maintenance prednisolone. And this is data, again, from our cohort, showing this over time, because what sometimes, if there's a large placebo response, particularly in younger patients, is that difference can be artificial between child and adult. So we wanted to look at it in terms of time to first exacerbation on the left, just to demonstrate to ourselves that this was a real thing. And what you can see here is you can see that the patients with child onset asthma started to exacerbate sooner than the patients with adult onset asthma. And just as a comparison on the right, you can see the difference between atopic and non-atopic made absolutely no difference in terms of when the patients were exacerbating following eosinophil depletion with benralizumab. Dupilumab is the same. So dupilumab, the anti-IL-4 receptor biologic, is actually the same, shown here with the age of onset. The only drug, actually, the only biologic where there isn't a clear difference in this way of the new biologics is tezepelumab, anti-TSLP. And what you can see here is in the child onset patients with age of onset less than 18, actually they still had about a 50% reduction in exacerbations compared to placebo, compared to the older onset patients. And this again speaks to potentially the difference in terms of mechanisms of child and adult onset asthma, the role of the epithelium, the role of TSLP versus the role of sort of intrinsic, almost autoimmune inflammation of the eosinophil, which we see much more in adult onset asthma. So to summarize, clinical trial and real-world data using the anti-eosinophil biologics confirm the central role of the eosinophil in exacerbation pathogenesis, area hyperresponsiveness, and poor symptom control. And this is the reality in the majority of patients with severe asthma. Approximately 75% of patients completely stop exacerbating when you remove the eosinophil with benralizumab, which is the eosinophil depleting biologic. About 80% are able to completely stop systemic steroids, again speaking to the key role of the eosinophil in patients requiring maintenance prednisolone, assuming they're on maintenance prednisolone for the right reason, rather than just being given it because of symptoms that actually don't even have a T2 etiology, like obesity or something else. Targeting the eosinophil is sufficient in the presence or absence of allergic inflammation. Adult onset asthma in particular is very eosinophil driven. Isolated targeting of eosinophilic inflammation, it does appear less effective in child onset asthma. When you look at sort of indirect comparisons, as I've shown you today, between tezepelumab, anti-TSLP, and the other biologics, it does suggest that non-eosinophil TSLP-induced pathways are more critical in child onset asthma. There appears to be a subphenotype within severe eosinophilic asthma, and here we're defining severe eosinophilic asthma at least a blood eosinophil count of 300 cells per microliter. A subphenotype who are actually not responsive to eosinophil depletion, but are very responsive to dupilumab, anti-IL-4 receptor. In total, this makes up about 5% of severe T2 high asthma, and this is based on a cohort of about 600 patients in our center treated with benralizumab overall. What characterizes these patients is a very high FeNO, which is in keeping with this idea, the notion that there is an IL-13 dominant phenotype in these patients. So it just leaves me to thank you again for the introduction and the opportunity to speak. This is my team over at Guy's Asthma Centre, which is part of King's College London and the NHS Trust, who have collected much of this data. As you can see, this was at the Christmas party a year or two ago. Thank you very much.
Thank you, sir, for that informative lecture. Ladies and gentlemen, we also have the privilege of having Professor David J. Jackson online. If you have any questions, now would be the best time to ask.
Professor Jackson, I'm Dr. Gunasekara. In our part of the world, you know that tropical eosinophilia is quite prevalent. And how would that interpretation of this and the efficacy of your biologics in this kind of scenario where wheezing and TP is coexistent?
Thank you very much for the question. So, with whether you're living in Sri Lanka or the UK, because there's a large immigrant population as well, it is always important, if the history is suggestive of a helminth infection, to screen for those. It's important to remember that systemic steroids suppresses eosinophils as well. So the notion that T2 biologics are actually more dangerous from a helminth perspective than steroids is actually wrong. What we increasingly appreciate is that broad anti-T2 suppression, which is essentially what you get with systemic steroids, is more harmful than targeted anti-T2 biologics. And we see that simply by looking at the literature on number of cases of, for example, strongyloides hyperinfection with systemic steroids. In fact, there hasn't been a single case report, not even one yet, of one of the eosinophil depleting biologics with helminth infections in parasites. From the mouse models, what we see is that that if you knock out one thing, for example, just the eosinophil, that actually in many helminth infections, it doesn't make that helminth infection in mouse models more severe. What appears to be the case is that there is sufficient redundancy across T2 inflammation such that you actually need to hit it more broadly for there to be a problem, which is why we see it with systemic steroids and actually not targeted biologics. So the key thing, though, is, which is with systemic steroids as well, is that anybody who's having systemic steroids on a repeated basis or on a daily basis should be screened for parasites, especially if there's anything in the history to suggest one.
Just to add on to that, in your cohorts where you have been using biologics, what was the side effect profiles like? Was it, have you been looking at that? Because when we are using this in the general population, obviously we will have to be looking at that very carefully, isn't it?
Yes. No, these are really well-tolerated drugs, certainly when you consider what we had before, which was only systemic steroids, and the terrible side effect profile of systemic steroids with obesity and osteoporosis and diabetes and so on, that we're all very familiar with. The biologics are really well tolerated. Very, very few patients have actually any side effects. Probably 1 in 20 might sort of have a headache initially or something like that, but really they're very, very well tolerated. I can count on one hand the number of patients that have actually wanted to stop treatment because of a side effect, actually.
Thank you, sir. Do we have any other questions?
So regarding the use of the system, so in our part of the world that we don't have asthma biologics, none of the asthma biologics are available in our country. So in difficult to treat asthma, so beyond step 4 or step 5, what would be the correct trade-off between the steroid side effects and the steroid use? And what is your opinion about using triamcinolone, which is considered to be having a less steroid side effect profile compared to the other steroids? Intramuscular triamcinolone instead of oral systemic steroids.
No, thanks for that. I think the first thing in terms of steroid stewardship, which is essentially what, and I totally appreciate that biologics are not available everywhere yet. Hopefully, they will be in the coming years. The key things about steroid stewardship are probably threefold. Number one is really making sure that inhaled delivery of steroids is at the maximal level. So, 2,000 micrograms equivalent of beclomethasone, and that adherence to that is good, and that inhaler technique is correct. Because so often, either adherence or inhaler technique is actually not good, and it is that underpins poor asthma control, and therefore the patients continue to require systemic steroids. And the evidence for this is simply looking at the placebo arms of the biologic phase 3 studies, which were the steroid-sparing studies. Sirius for mepolizumab, Zonda for benralizumab. The most recent study for tezepelumab was called SOURCE. And SOURCE, what was interesting about SOURCE was 46%. It was a negative study, but that was really because 46% of the patients randomized to placebo were able to stop the systemic steroids. Why? Because the doctors who put those patients on them in the first place didn't put them on for the right reasons. Either they went into the clinical trials not using inhaled steroids regularly, and then the research nurse who recruited them optimized their inhaler technique, reminded them about adherence, and actually the T2 inflammation they did have melted away with the inhaled steroids, and therefore there was nothing left for the systemic steroids to act on. Or actually the doctor didn't realize that the symptoms the patient was complaining of had nothing to do with T2 inflammation. Those were the symptoms being driven by chronic bacterial infection or obesity or laryngeal obstruction or anxiety. So that's the first thing. And in line with what I've just mentioned, that last part, is unless you use biomarkers, you will mismanage your patient. Because a patient sitting in front of you who's very symptomatic, those symptoms can come from either their asthma or other causes. If it's from their asthma, it will be coming from two things, either their airways inflammation or airflow obstruction. Unless the symptoms are coming from airways inflammation, those symptoms are not going to be responding to systemic steroids. And all you're going to be doing is poisoning the patient with systemic steroids, giving them all the side effects without any of the benefit. So it's very important to use the blood sample count, FeNO if you have it, to at least allow you to understand, hang on a minute, are these symptoms likely to be steroid responsive? Because if you have a patient who's very symptomatic with an eosinophil count of 50 cells per microliter, it's highly unlikely that those patients' symptoms are being driven by airways inflammation. And actually, when you give them prednisolone, it makes no difference to how the patient feels. In that scenario, don't just keep on escalating treatment, as though the reason for the non-response is dose. It's not. The reason for the non-response is symptoms that have no basis in airways inflammation. So it's very important from a steroid stewardship perspective to use biomarkers in that way so that you're confident that the etiology of symptoms is inflammatory, and making sure inhaled therapy is optimized to make sure that you're not escalating inappropriately.
Can I ask a question?
Thank you, sir. Do we have any other questions?
My question is on bronchopulmonary aspergillosis and aspergillus sensitized asthma. Do you see omalizumab being first line over the steroids, or do you think it still would be salvage?
I would always use biologics as first line over steroids if biologics are available, because they're so much safer. I think what's important to appreciate with ABPA or any inflammatory condition is, especially with ABPA, is that steroids, although they're very good at suppressing inflammation, T2 inflammation, they impair host defense against fungus and bacteria. So what you end up doing is making it more likely the patient's going to develop an invasive disease, because you're impairing the ability of the lungs to control fungal replication, actually. But what the steroids are doing is preventing the inflammatory response from a T2 perspective. But actually you're basically making the patient immunosuppressed. And we know what happens with immunosuppressed patients in fungus. So if you have the option to use biologics, that should definitely be first line. We've published very good data on using anti-IL-5 therapy, so mepolizumab, benralizumab, in patients with severe asthma with fungal sensitization. Some of those had ABPA, radiological ABPA as well. Fantastic outcomes, because in that scenario, you're able to suppress the eosinophilic inflammation. Remember, in ABPA, the mucus is very eosinophil rich there. It's the mucus, which is very eosinophil rich, is almost acting as like a perfect medium for germinal replication of fungus. So if you can get rid of the mucus, the eosinophil rich mucus, which is what you can with benralizumab, for example, patients do very, very well. Omalizumab also, in some patients, but not in all. But the bottom line is, if you have the opportunity to use a biologic, always use it over systemic steroids. It's much, much safer for the patient.
Just a comment on that. We have this concern where patients' serum galactomannan antigen becomes positive and they are diagnosed, they fulfill ABAP criteria. So we are wondering whether how safe the steroids are. So you have answered that question, I think. So if the biologics are available, you would opt as first line in these cases with overlaps also.
Yeah. Anyone who, look, whatever the driver for the inflammation, whether it's fungal sensitization or a different kind of sensitization, or if it's just intrinsic, the biologic is always safer than steroids and should be used first line if you can. I appreciate it's not available in some healthcare systems, but if it is, you should always try and use it first line because it's without question safer for the patient. It'll also allow you to use a lower dose of systemic steroids if you do have to add systemic steroids. But the first thing is, try to not immunosuppress your patients. And don't forget that the combination of steroids and antifungals, makes the steroid dose much, much higher. So you're much more likely to create steroid-related comorbidities and give the patients diabetes and osteoporosis and so on by combining antifungals with systemic steroids. So it's always best to try and use the biologics, and if necessary, you could add the antifungal if the fungal load is the issue.
Thank you very much. Thank you.
Thank you, sir, and thank you, Professor David J. Jackson.